landscape in Canada where service delivery is more intense, smaller number of clients receiving more hours of care, more specialized care that's more nursing type services, less housework as it was 2 decades ago, described in terms of home care, and the real focus on the acute post-hospital focus, a move from a prevention focus, which was the case in many parts of Canada in years past. So these are two, more than the baker's dozen here refers to the fact that we have 10 provinces, 3 territories, more than 13 ways of delivering home care services in Canada. We have a crapshoot. It's been described as a checkerboard situation. And as our late colleague Evelyn Shapiro described more than a decade ago, this is still very much true. Where you live in Canada, rather than what you need, determines your access to services in terms of home and community care. So in terms of 2 of the 3 issues which have been identified in my work with groups across Canada, scope of services is referring to the mandate of these unregulated workers going into the home. The work that they do is determined in terms of care plans. And one of the real challenges is tremendous variability in training from one area of the country to another. As clients' needs become more and more complex, you see in different areas of the country what's called delegation of task. And in British Columbia, we know that approximately 50% of all clients of home care have this order called delegation of task, which means that the worker coming into the home has actually, for this client, been told that there are some things that they can do that are normally outside their scope of practice. So it's trying to recognize on a case-by-case basis that, in fact, the way the system is set up for delivery isn't meeting the needs of the clients. And you could argue, if that's becoming true of 50% of the cases, then we have a real issue here in terms of the match between the training and scope of practice of these workers and the situations they're encountering in the home. In Ontario, Margaret Denton and colleagues at McMaster have referred to this as task shifting. We can talk about that in a couple of minutes. And I think it's just important to note, in terms of this scope of services, a final comment, home care or home support is often referred to as the eyes and the ears of the healthcare system coming into the homes of individuals. So it's quite important that what happens in that context is meeting client needs and reflective of what they need on a given day. Scheduling of services, again, sits at the heart of what home care is all about. Typically in organizations where there may be regulations on seniority of workers, etc., what the model traditionally is that one client has many different workers coming in. Sometimes a client may not see the same worker from one week to the next, and you can imagine in the context of dementia care the particular challenges that arise in relation to that. And certainly in the data I've collected, family members and clients themselves will talk about the challenges in lack of continuity in terms of the relationship between the worker and the client. This not only threatens the relational aspects of care, which we know are actually very important motivators for workers to be in this sector. They like developing relationships with and knowing the people that they're caring for. Also, as I said, particularly important for continuity for individuals where there may be some confusion in the early stages of dementia. There are some initiatives underway in a number of provinces, for example, to try to attract more workers into this sector through waged weeks, for example, because this is a sector which is dominated by what we call a casualization of labor. Workers often don't even know at the beginning of the week how many hours of employment that they will have. So you can imagine how that dynamic plays out in terms of these issues of scheduling. In some areas of British Columbia with which I'm familiar, model models have been developed around what's called cluster care or neighborhood care, where you might have a roster of 3 to 4 workers assigned to an apartment building or to a particular neighborhood. And the idea here is to try to bring more continuity of service provider in an environment, and then that individual is able to respond more rapidly when a crisis arises for a client, rather than having to wait for their scheduled appointment later in the week. The third quick area I want to identify, and I know this will be picked up in sessions a bit later this afternoon, when I say family and friends mind the gap, there's a broad recognition that family and friends fill the gaps of limited scope of services in home and community care. These two examples of data give you a sense of just how prevalent the presence of family members, and also many agencies, and indeed in the policy statements in British Columbia, it's written in, the assumption is that home and community care services supplement and complement family and friend care. So there is an assumed or presumed availability of family and informal carers, even at the same time that managers and policy analysts will admit that they have no idea how families are utilizing services. There's no integration in terms of respite care, adult daycare. These systems operate in isolation from one another. So the assumption is of the availability, but largely in a policy context, care for family members later in life is considered a private trouble. We have a system that is essentially reactive rather than supportive. And I'll just show you in the Vancouver Sun this very week, the headline above the fold was, "Caregivers in BC have high levels of anger, worry, and stress." This is the report of the BC Ombudsperson, a real recognition of the costs to the system in terms of care. So my final slide, there's a projection that within a very few number of years, 68% of older people with dementia will be living in their own homes. In British Columbia, at least today, approximately 30% of the clients of home and community care are recognized as having dementia. We know that these are people who in the past would have been living in long-term care facilities. So they are, as one manager said to me, they are where they should be, which is in their own homes. The challenge is we don't have all the systems in place to support them. There is a recognition that as we anticipate that increase in the proportions of older people with dementia in home settings, our challenges remain in this sector: worker shortages. A fundamental issue, in fact, is that workers in home and community care do not have wage parity with workers in residential care. We have a system that motivates them to move on to long-term care. That is something that could be addressed immediately. I'll also acknowledge that in various parts of the country, we have initiatives with names like Home is Best. That's the Fraser Health Authority in British Columbia, the Home First Initiative in Ontario, Better at Home in other places. And these recognize that, in fact, they give some priority to a system to get people out of hospital into the home care sector, but they're often very focused on the immediate 2 weeks post-acute hospital discharge, and not at all oriented to the chronic care needs of the individual with dementia. So as Monique Bégin, our former Minister of Health, said some years ago, Canada is a nation of pilot studies. So we have many pilot studies across the country to try to put some backbone to the Home is Best initiative. But in fact, as I think we'll see throughout the course of the next 2 sessions, we're a long way in Canada from integrating a range of initiatives on a continuum of home-based and community care to serve the needs of older people with dementia. Thanks for your attention.